Untangling PANDAS and PANS is a podcast about two little-known medical disorders characterized by the sudden and dramatic onset of symptoms such as obsessions and compulsions, vocal or motor tics, and restricted eating behaviors, and a whole host of other symptoms following a strep or other bacterial or viral infection. I have the privilege of interviewing some of the top researchers and clinicians in this rapidly growing area, known by various names such as immune-mediated neuropsychiatric disorders, infection-associated neuroimmune disorders, and autoimmune encephalitis, or simply PANDAS and PANS. My name is Dr. Susan Manfull. I am a social psychologist, the executive director of the Alex Manfull Fund, and the mother of Alex Manfull, who died at 26 years old due to PANDAS, a disorder my husband and I knew next to nothing about, certainly not that our daughter could die from it.
This is episode 5 of Untangling PANDAS and PANS, recorded July 25th, 2024.
Dr. Earl Harley is a pediatric otolaryngologist at Georgetown University in Washington, D.C., where he is also an associate professor of otolaryngology and pediatrics. Georgetown University has been his professional home for over 30 years. During his very distinguished career, he has been the recipient of many accolades and awards. Dr. Harley has also had a long, distinguished career in the U.S. Navy from 1972 to 1993, when he retired as a Navy captain. I have had the pleasure of knowing Dr. Harley for over 5 years, because one of his passions in medicine is working with patients diagnosed with PANDAS or PANS. One of Dr. Harley's passions outside of medicine is golf. So on the golf course is where you might find him on the weekends. Okay, Dr. Harley, let's get started.
Okay.
You are an otolaryngologist. Mm-hmm. You know how long it took me to learn how to say that? You may remember when I introduced you at the Georgetown MedStar conference, right, and stumbled over that word.
Well,
anyway.
That's the short version of it. Otolaryngology is the long version.
Oh, gosh. I'll okay. Aspire to that.
Thank you. Thank you for the opportunity to just kind of talk about something that's really, really close to me, something that's a passion. As we just talked about, I just finished operating on a 19-year-old with PANDAS who nobody would believe. And so they come, from near and far, basically.
And other countries.
And other countries.
As I understand it.
Other countries, England, Sweden, to name two.
We'll start off with some basic questions.
Okay.
What is an otolaryngologist?
Yeah, otolaryngologist is basically an ear, nose, and throat physician. And I specifically is a pediatric otolaryngologist, so I've done extra training to take care of children.
Okay. Mm-hmm. So shorthand name is an ENT.
ENT, right, yes.
All right. And can you tell us a little bit about how you came to be an ENT?
Oh, very interesting. So it was like many things in life. It's not a straight line. It was not a straight line for me either, because I never intended to be an ENT. As a matter of fact, I wanted to be a neurosurgeon. And that was my initial goal. And for one reason or not, I never even applied to be a neurosurgeon. So I just found other interests. So the first interest was pediatrics. And then I married the pediatrics with the ENT and did a fellowship. So at first I did pediatric training, then I did ENT training, then I came full circle and did pediatric ENT. But it was something. But ask how? It's through my experience in the military, by the way. That's exactly how. So I was in the Navy, and I was a Navy flight surgeon. And one of the things you do as a flight surgeon is you take care of pilots who are very healthy people, except for ear, nose, and throat. They have lots of sinus issues.
Oh, interesting.
Yeah, lots of sinus issues, have allergies and sinus. Otherwise, they're very healthy. And so it was that experience. And so if you talk to other people who were flight surgeons, a lot of them are ENT. It's just a natural gravitation towards that because you were so used to taking care of these things when you were on active duty. So that's kind of what got me interested in ENT, because I knew nothing about it except from medical school, but I knew nothing about it.
I had not thought about that connection.
Yeah,
that's very interesting.
Exactly true.
So our general conversation is going to be about the role of an otolaryngologist in treating PANDAS and PANS. But let's get some other words out of the way as far as exactly what they mean. Tonsils. What exactly are tonsils?
Well, tonsils are part of the body's immune system. They help fight infection, but they're not the primary part. They're more of a secondary line of defense, but they do have a role in immunity in host defense. So when you breathe in or swallow something, the tonsils go into action. They're antibodies that are produced that help fight these infections. So they're but they're only a part of the immune system. There are adenoids there. There are other tonsil tissues in the back of the throat, but the tonsils are the main ones. So.
And what do the adenoids do?
Well, the adenoids do the same thing as tonsils. There's a ring of tissue around the back of the throat. We call it Wall-Dyer's ring. And so the adenoids are part of that ring. The tonsils are part of that ring. And you have a second set of tonsils that we don't even talk about. That's also a part of the ring of tissue, all of which have that immune function.
Okay, so when you do a tonsillectomy, you're removing the tonsils.
Removing the tonsils.
And
well, let me say, there are different ways to do tonsillectomies. There's one way you can do it where you don't remove the tonsils. So, right.
That's news to me.
Well, it's a partial removal. We call it intracapsular, where you just kind of scoop the tonsil out.
Scoop out the contents?
Yeah, intracapsular. So if I can explain how because we have a little simulation lab that we do. So I take a white potato, which I'm going to do tonight. I boil it, and then we bring it in, and the white part of the white potato would be the tonsil, and the skin would be what we call a capsule. So you just scoop out the white part. That's called intracapsular. So that's the technique that we use to teach that type of tonsillectomy.
The potato.
A white potato, yeah. A boiled white potato.
Who knew?
Yeah, yeah, boiled white potato. So, but for PANDAS, I don't do that. I don't want to leave tissue behind, because when you do it that way, you leave some behind. As a matter of fact, when you do it that way, it can grow back. That's really the downside of doing that with that technique.
When you do the surgery with someone with PANDAS or PANS, do you take out both the tonsils and the adenoids?
Yes, I do. And that was at the urging of my friend and colleague, Dr. Elizabeth Beth Latimer. And so when I first got into this years ago with her, she kind of insisted that I do both. And it makes sense, actually, because as I just explained a few minutes ago, the adenoids are part of the same system of tissue as the tonsils are. So it made sense. And also, as you know, from the work from Georgetown et al., who looked at in the animal model, looked at what they call the nault tissue, which was the equivalent of adenoids in adults. And they showed that from the nault tissue, that's where it crossed the blood-brain barrier into the basal ganglia. So it makes sense to take the adenoids out, because it's actually closer to the brain than the tonsils are. So,
oh, okay.
Yeah, because they sit high. Adenoids sit high in the nasopharynx. That's the top of the throat, by the way. Nasopharynx would be the top of the throat. And from there, you're in the brain, basically. So, yeah. So it makes sense to take the adenoids out.
All right. Well, let's talk a little bit about, we talked a little bit about how you got into the role of an otolaryngologist. How did you get into the role of an otolaryngologist who works with PANDAS and PANS patients?
Right. Well, like I said a few minutes ago, it's not a straight line. It was through Dr. Latimer, a colleague of mine who actually took care of her kids as well. But anyway, one day she asked me to see this child with PANDAS, and this was years ago, over 10 years ago. And so there was one child, and there was another, and then there was just one after another, and so we collaborated on some things. We've actually collaborated on a few projects, and it just went from there. So that's how I got. So I knew nothing about, like most people I know knew nothing about it. But it was through that experience.
Well, speaking of Dr. Latimer, she always reminds us that tonsillectomies were very common in the United States between the 1950s and 1970s. Basically, everybody I grew up with had their tonsils removed.
Yes.
I still have mine, but she said that's, well, a figure I have here is more than 1 million a year.
It was.
And so today, do you know off the top of your head how many are performed each year?
Yeah, the numbers went way down. They went to like the 300 to 400,000. It's creeping back up. It's probably close to 500,000 now. But it was the most common operation done. It was right. It was more than 1 million a year. And always, because I talk about this a lot. As a matter of fact, I even when I lecture on this, I sometimes show a picture from the Pittsburgh Gazette from 1971, where there's a whole family getting their tonsils out, because that's what was happening back before the 70s. But what I explain is, why did all of a sudden, at one point, everybody's getting their tonsils out, and you no longer need your tonsils. I mean, you can now keep your tonsils. And you have to go back 100 years to explain. Like, history is so important in understanding a lot of things. And it's really critical to understanding why the rate of tonsillectomy dropped. Well, 100 years ago, there was no penicillin. There were no antibiotics. So the way you control rheumatic fever is to take the tonsils out. And so people, even after penicillin and sulfurs were developed in World War II, they continued until somebody said, well, wait a minute, we have penicillin, we have drugs, antibiotics. So we don't have to take everybody's tonsils out. So all of a sudden there's a sharp decrease, and it has to do with the introduction of antibiotics, so you can now treat. So that's why.
I didn't realize that either.
Yep. Mm-hmm.
So tell me, what is, I'm going to like to get into some of the research a little bit later in any cases you want to talk about, but just generally speaking, what's the theory behind tonsillectomies and as a treatment for PANDAS and PANS?
Yeah. Well, as you know, when Dr. Sweeto described what she called PANDAS, 1998, let's get back. So she was at NIMH studying Sydenham's chorea. Sydenham's is a strep-related, it's a movement disorder. And so what she noted was a subset of children who had these anxieties and, these neurologic symptoms. And she coined the term PANDAS, based on, and the S in PANDAS is strep. Well, tonsils are a target organ for strep. So the theory was, okay, if it's strep related, if you take the tonsils out, you reduce the strep, because we know that tonsillectomy reduces the rate of strep carriage. We know that. Although you can still get strep even without tonsils, but tonsillectomy does reduce, and that's been well documented.
Tonsillectomy reduces strep in people who are prone to strep infections.
A number of strep infections, even though you may still get 1 or 2, but you won't get 7 or 8. So the theory was, if this is strep targets the tonsils. If you take the tonsils out, you reduce the strep. So it kind of followed. It kind of made sense, and that was how we still operate on that basis today. Although there are other sites, strep can be other places, not just the tonsils.
So when you take out the tonsils, what do you find in those tonsils?
Oh, well, sometimes you find stones, tonsil stones.
What are those?
Just little white stones. Little white excrescences, actually. But it's a stone, like the one I just did last hour ago. Had stones in his tonsils. They're not like hard, they're not pebble, they're kind of soft, but they're tonsil stones, or we call them tonsilliths is the medical name. So we find that.
Are those bacteria?
They are bacteria. They're bacteria. There's bacteria in them.
Okay.
Yeah, bacteria.
That over a period of time have just coalesced, or?
Well, they're like crevices in the tonsils. Like a tonsil kind of looks like a sponge, and you have these and so these bacteria, food gets caught in there, bacteria, and some of the epithelium, and it forms these stones over time. And it's actually a source of bad breath because they get bacteria, you got decaying bacteria in there. So people with tonsil stones have bad breath. Actually.
I did read that was a reason that tonsillectomies are done. Halitosis.
Halitosis, yeah, it's right down at the bottom of the list. Halitosis, and the halitosis is based on the stones that are there, which are full of bacteria.
Interesting.
Yeah. Mm-hmm. Well, we find scar tissue. I mean, a lot of these patients who've had multiple infections, the tonsils are very scarred in. So if you take say a 3-year-old who comes in just for snoring and they have not had a lot of infection, well, they have nice, I call it clean planes. In other words, it's not scarred in. They just kind of almost kind of jump out at you. Whereas opposed to the 19-year-old I just did an hour ago, very scarred in, just kind of not concrete, but really tough tissue, just digging through, just kind of, I guess digging is the wrong word, but really kind of getting having to work at it, as opposed to like a 3-year-old. It's quite a different operation.
So you find strep and any other kind of bacteria?
Well, we don't find a lot of strep. That's interesting. We don't find a lot of strep, which is interesting. So as you know, we've done multiple studies, and 2 of the studies we looked at the bacteria, the microbiome, and in our first study, I think we found no strep in the. So these were controls versus PANDAS. So the control group had strep, but the PANDAS had none, and so in our second studies found similar things. And so when I was reviewing this last night with my student who's helping me, we looked at a study from Germany, I believe. I think it was Germany. Anyway, I just looked at it last night. They found exactly the same thing. They cultured everybody. Their study actually looks like my study. They did the same stuff that we did. And they cultured everybody. They only found one bout of strep, one case of strep in the cultures. So we're not finding strep.
What do you make of that?
A good question. So we are starting to think that the number one, strep may be the precipitating infection, but it could be almost anything, because we find more of everything else than strep. We think that once they become predisposed or primed for this, almost any bacteria. So it's an antigen-antibody reaction. So the antigen is the bacteria that drives the system. So it means even if there's no strep, it may make sense to take the tonsils out, because if the tonsils are full of bacteria, and they are, because we culture every one of them, and we get 3, 4, 5 bacteria out of these tonsils, although very little strep. So we're removing the antigen, which is the driver of the system. So this is kind of theoretical, but I've talked to our immunologist about this, who actually gave me the idea. It's the imbalance in the system with the bacteria driving. So we can remove the source of the antigen, which are the tonsils, and then we can rebalance the system. So
the control group tends to have strep.
Yes. Mm-hmm. In that one study, yeah. In
the one study,
yeah, right.
Okay. Mm-hmm. Did they have all sorts of other bacteria as well?
They did. Yes, actually one of the slides I showed up at your conference last time. But anyway, so I compared, and so the control group had strep. The PANDAS group didn't. The PANDAS group had more anaerobes, like fusobacteria, whereas control. So there was a clear difference in the two, in the microbiome between the two. The PANDAS group had some staph, and there's another study from Minnesota that Dutan was involved, Pat Cleary, Dr. Cleary. That's actually how I got involved in the research, was through the work they were doing at Minnesota. But anyway, they looked at staph. It showed, at least in the lab, staph had the same impact as strep as far as the Th17 response. So it was interesting. Yeah, it was interesting that there was staph and I find more staph than strep in these tonsils. And when I say strep, I'm talking about the beta hemolytic strep, because there's different streps. There's different serotypes of strep. We're talking about the group A beta hemolytic strep. That's the one that's the bad actor. Mm-hmm. But we find very little of that. Mm-hmm.
And when you say anaerobic bacteria, is that the bacteria that can't survive?
Yeah, it's full of this anaerobe.
Okay.
And what's interesting to us, how we put this, is that this particular one, the Fusobacterium, has been associated with other neurologic. So it's not just this. It's Alzheimer's is one, and I think multiple sclerosis. But there are a couple other central nervous system disorders that are associated with this same bacteria.
The same anaerobic bacteria.
Yep,
that's really interesting.
Fusobacterium, yep. Mm-hmm.
So when you take the tonsils out, how does that affect the way the body responds to infection?
Well, a good question. It doesn't, and there have been multiple studies. There's always a question that parents have: if this is a part of your immune system, what's going to happen? Well, one of the ways I explain it is that there's other tissue in the back of the throat that takes over that role, but like other parts of the body, there's redundancy. Like you can take one kidney. You don't only need one kidney really. Or you can take your appendix out and not miss them, or your gallbladder. So there's enough redundancy in the immune system that it does not impact. And the studies have shown that. It's not just anecdotal. The studies have shown after tonsillectomy, they've drawn immunoglobulins, and there's really no demonstrable decrease in immune level. So yeah, so it doesn't affect them.
Let's talk a little bit about the research. So at this time, as I understand it, the American Academy of Otolaryngologists, head and neck surgeons, does not endorse the surgery for PANDAS.
Right.
Now, I'm going to guess that that's because there isn't a lot of research that's been done.
Yeah.
Can you elaborate on that a little bit?
Right. So the first, and these are the guidelines. The kind of guidelines, the kind of things you go by is not. I mean, you're not penalized if you don't follow the guidelines, but these are general guidelines for how you operate. So the first guidelines came out, I think, 2011, and they didn't recommend tonsillectomy for PANDAS because they said it was unproven. And then the second guidelines came out in 2019, still didn't endorse it, said there wasn't enough information on it. So our academy does not endorse it unless you meet what's called the Paradise criteria. I don't know. So Paradise criteria is a group of indications for tonsillectomy based on the number of strep, or not just strep, but actually infections, but based on the number you've had. So Paradise, who was a pediatrician in Pittsburgh Children, says if you have 7 infections in 1 year, or 5 infections per year for 5 years, times 2 years, or 3 infections per year times 3 years, then any one of those 3 meets the guidelines, the indications for tonsillectomy. So the academy says unless you meet the Paradise criteria, then surgery for PANDAS is not recommended. I guess they may not say as much because they have to be careful. The wording, the way you word things, you have to be careful. They don't say you can't do it, but it certainly doesn't meet the guidelines.
But there's a lot of anecdotal information.
Yeah, a lot of anecdotal information of improvement after tonsillectomy. And what's lacking is prospective. There are some prospective studies. I know there's one from Germany, but really there's not a lot of prospective studies with just to follow these kids who don't get treated and see what happens.
And the ones that do get treated, at what point do their symptoms begin to remit, and do they stay absent?
We have some patients who, when they come back for their post-op in 2 or 3 weeks, they've already seen there's a reduction in tics, or other behavior changes. And then there are others who don't. But there are clearly some who parents are very pleased that they're less aggressive or things like that. So yeah,
I can't remember the authors of the study in which parents were interviewed, and they felt extremely positive about the surgery.
You may be talking about our study because we did.
Was it you?
We did that study. We did a study like that.
Okay.
Where we interviewed it was retrospective, yeah. But it wasn't every parent, though. But a majority were positive and said they would do it again. Yeah.
Can you talk a little bit about the number of people who do tonsillectomies for PANDAS patients?
A handful. I've talked to people more and more. I'm actually hearing more and more who do it. You know, it's like something you do but you don't talk about. I mean, because and I talk to, I'll do that. But they don't really, it's not really talked about. They're not big advocates of it. But as I talk to people around the country, we'll do it. Yeah.
Yeah.
We'd love to, I love to have, I call it a study group, just a group of like-minded, ENTs, like just talk about common, issues that we're running into, how we can advocate for.
So as you've made clear in your talks at our symposium and in my conversations with you, that this is a serious procedure, and so it's very careful that it's very important that you choose your patients carefully in order for success to occur. Can you talk a little bit about how you select the patients for this procedure?
Yeah, that's a good question. We're very careful in selecting the patients because we're out there on the limb. We're out there doing something that our academy says there's no indication for. So we have to be very careful. And we do turn patients away. And that's what we want to actually refine that process by which we really decide who needs a tonsillectomy, who will benefit from it. Certainly if they have a strong history, if they have elevated strep levels in their bloodstream, strep titers, that's a strong indication to me. But if they don't, because some of the kids who come to us, they don't really have, they may have some tics, but it's really not. So we're kind of careful. Although, again, I'm not a neurologist, so and that's why I'm excited to collaborate with neurology here, because I think we could have a team that could really weed out who will benefit and who won't. So
me too.
But if they, if it's clear, if there's strep there, strong history of throat infections, elevated titers, we sometimes look at the Cunningham panel, although we can't put too much into the Cunningham panel because it's not specific for PANDA. It's a rather non-specific test. But it's tough deciding who needs it and who doesn't, because we don't. The last thing we want to do is have a complication and then say, the lawyer said, your academy says this surgery wasn't indicated, so so we have to be careful.
It's a tightrope to walk.
It is, yeah, and we turn people away, we turn patients away, and some of them are, not happy, but yeah.
So you and Beth have done some work having to do with tonsillectomies in conjunction with IVIG. Can you talk a little bit about that?
Right. So that was retrospective. That was a retrospective study. So looking at patients who have PANDAS, meet all the criteria for having PANDAS, and just divide them into groups, those who've had IVIG versus tonsillectomy. And then we looked at either IVIG before or after tonsillectomy, situation one was seemed to be more efficacious. And it seemed like the patients who had IVIG after tonsillectomy did better. And it seems to make sense, too. You get rid of the offending organ, and then the IVIG, because, you still have circulating autoantibodies in the system. So it makes sense. You get rid of the offending organ, which is the tonsil, and then you use the IVIG to kind of clean up the circulating antibodies. So that's what we found, is that tonsillectomy followed by IVIG was probably the best way to.
And I think you've mentioned to me that that's something you'd like to, an area that you'd like to pursue with more research.
Yes.
Okay. So I'm really excited about your proposal for a multidisciplinary PANS, PANDAS, autoimmune encephalitis clinic, a joint effort with otolaryngology or and neurology, or is it pediatrics and neurology?
It's neurology. Right now, it's just neurology. It's not pediatrics. They're not involved.
All right. Can you tell us a little bit about what you'd like to do, what you're proposing?
Our proposal is to have a multidisciplinary clinic once a month, maybe once or twice a month, where it's not just my team, but it's neurology. It's the both of us meeting together, seeing the patients together, and then first there'll be a screening process. So I have a student fellow who's with me for the next year, who's already starting to work on this in terms of who gets into that clinic. And we've actually worked with Beth already. He's already shadowed Beth, been to her clinic, her office. And so these are the questions we're going to use, the screening questions. So once they screen in, then they come in, they see me, my team, and the neurology team. And then we have a conference. Just like any other multidisciplinary clinic, there's always a conference afterwards. And then you come to a decision, candidate for tonsillectomy or other therapies. So that's sort of the rough proposal. We do have a meeting set up with Dr. Tornatore next Wednesday, I think it is. I think is the date that Wednesday afternoon. So we're going to get this out. We were hoping to get it off by August, but now probably looking at September. Yeah. So we'll start. And we're starting to tell patients that we're kind of holding off until we get this clinic organized the way we want it organized.
Okay, so you're going to develop a screening procedure, a series of questions.
Yeah, we're using. Yeah, Beth has already sent us the protocol. Nicholas Lamb is a student who's working with me. He's already got that laid out. So that would be our screening. There's some others. We're going to use the Yale, the Weibach from Yale. So there's going to be a series of screening questions.
Okay. So, as we've discussed, the Alex Manfield Fund has provided some funding for fellows in neurology that we're hopeful will also benefit other relevant departments. So, with this funding, we're hopeful that we can get the fellows interested in this subject. And in the case of working with you, they would be able to learn more about PANDAS and PANS, learn how to screen for whether a tonsillectomy makes sense, and also learn more about that procedure.
Right. Yeah, that's the goal. That's the goal.
That's really exciting. And then the other part of that proposal is something that you've wanted to do for a long time, and that is create the repository for tissue and blood samples.
Exactly.
Can you talk about the importance of that?
Well, the importance of it is, and I've already discussed it with Dr. Brent Harris, who actually is going to be on our IRB. So the importance is just having tissue preserved for, a year, 5 years down the road, somebody is a new analysis. So just having tissue available where you can go back and look at, other, maybe, well, for instance, Dr. Latimer is interested in, Bartonella. And so we are now actually going back and pulling some of the samples. As a matter of fact, this is like going on this week. Some of the tissue that we collected from our first IRB to go back and look for Bartonella, something that Beth is interested. So that's the rationale for something else comes up that 5 years down the road we can go back and pull these tissues and look at them.
Have you found Bartonella in the tonsil tissue before?
No, we haven't.
Probably haven't looked for it.
We haven't looked for it. So just now, like I said, within the last week, we're starting. We have looked. Well, we did look for it once. There was a patient from North Carolina. I can't remember the veterinarian name in North Carolina.
Edward Breitschweit.
And I did communicate with him. We actually were able to send him a sample, but he didn't find Bartonella in it. So that's the only time I look for it.
Once the repository is set up, in Dr. Brent Harris's bank. Can other otolaryngologists send tonsils to you?
I think so, because I've had offers already from around the country. Can we send? And right now we weren't set up to do it because when I first started, I was sending tissue to Minnesota with Dr. Cleary. Yeah, that was my first foray into this research. We would we didn't freeze them. I think we put them in a solution and shipped them overnight. So yeah, I mean, so we've done it. So I'm sure that once we set it up, the protocol, they can do it.
Well, we've certainly gotten inquiries about whether or not you can receive this type of tissue in the future. All right. Can you tell us a little bit about the typical patient who comes to see you with PANDAS and PANS?
Yeah. Well, the typical patient is one who has seen several physicians already, far and wide. Many are from local, but many are from elsewhere. They're desperate. Typically, they've been to some very famous institutions, I won't name them, who says we don't believe in that, or there's no such thing. And so they come here in desperation, just asking for somebody to just believe that my child is, this is not my child. There's like overnight, sometimes it's like a light switch. All of a sudden there's OCDs and, tics. And so they come in here in desperation. And oftentimes there's a family history of maybe some other autoimmune. It's actually very common that there are other autoimmune diseases, not just PANS and PANDAS. Typical, usually Caucasian. Something we've investigated. We've seen very few minority patients of any minority. Hispanics, Black, you name it. It's mainly Caucasians that we see this in, and we don't know why. We don't know if it's genetic or it's just a lack of recognition, or there's a suspicion that these children, because many of them they're anxious, they're acting out, and so they may just be, okay. And I do have a good example of one kid who was going to be admitted to psych, who was cured with penicillin, basically. So
they may be getting different diagnoses, like a conduct disorder, for example.
Yeah. ODD, what is it called? Oppositional defiance disorder, thing like that. And so, you got strep throat. Yeah, let's take this amoxicillin, and all of a sudden your behavior improves. So we don't know if that's the issue, but we do know that most of the patients are Caucasian.
And I know from my other conversations with you that is something that you'd like to see more research done on.
Right. I did mention that we have a poster accepted for the Denver meeting in November. It's called Society of Ear, Nose, and Throat Advances in Children, which is a smaller...
The Society of what?
Ear, Nose, and Throat Advances in Children. It's called SYNTAC, Ear, Nose, and Throat Advances in Children. It's been accepted for the meeting in November. And that poster is urging pediatricians to do a throat culture on children with sudden behavioral disorders and trying to increase the recognition. And so I'm saying that to say I don't know if more minority kids would be picked up just by, diagnosed appropriately by just doing a throat culture in somebody who's acting out. So we don't know.
Well, that's a good hunch that would be the case, though. And right now, the AAP, the Red Book, does not suggest.
Does not.
And doing a strep test.
Does not.
For the sudden changes in behavior and the psychiatric issues and so on.
Which is a shame, because the American Academy of Pediatrics is the biggest voice. It's one of the biggest voices, right here in D.C. They have an office here. They're up on Capitol Hill. They could be an advocate, but they're not. They refuse to be. And if they got on board, the pediatricians would follow, and it would be taught, but they're not on board. So,
Okay. Are there any studies that you would like to initiate in the near future?
Yeah, the genetic testing that I just talked about, I think some genetic, because it's clearly genetic disorder. Because sometimes we've had more than one child come in the same family. We've had the most I've had was 3 in the same family, and also then the parents as well. I had some of the same symptoms, or some parents say, "Well, I still have it." Yeah, I still have it. So there's clearly a genetic connection, and I know there's some work being done with this. Yeah, I think that's so that looking for a marker, a marker for this disorder, and we think we found one, and it's not specific to pandas, but we found the same thing they're finding at Stanford, is that the IL-17 is elevated in these kids, and we found the same thing. And so there's treatment for interleukin-17, anti-interleukin-17 treatment. So is that a marker? I think it's a non-specific marker because it also is elevated in other autoimmune disorders. So, so pursuing that.
So you've found evidence that it's elevated in the clients in which you've taken the tonsils out?
Yeah, this is comparing controls to the pandas. So this is a control study. And these are prospective studies, because studies that I'm talking about are prospective. So they was not like we look back at this. These are where we enroll families right up front and looked at it. And the IHC, which is immunohistochemistry data, shows that the interleukin-17 is elevated in the pandas group, and is statistically significant elevation of IL-17.
Yeah, I think that path is going to lead us to some interesting information with Jatan Agaloo at Columbia working on that, and Kyle Williams at Harvard MGH is also working on some research having to do with IL-17. So if we could just get some nice funding from NIH.
That's I think it's exciting, because if that's the treatment, if all you have to do is use a IL-17 inhibitor.
That's right.
Yeah, so
that's right. One question I don't have written down here, but I just thought about it. How is this addressed in medical school?
Oh, it's not.
Not at all.
Because the students come through, I'll ask them. They've heard about it. Yeah, they've heard about it, but because most of them have heard about it.
But the role of tonsillectomy?
Oh, no, that's not.
It's not?
That's stuff.
Okay, so we're very fortunate to have you.
It's not addressed. Even the pediatric department, they don't. They're not on board with it, so, which is unfortunate. Which is part of the big issue, because parents. I mean, one of your favorite. As a parent, one of your favorite people in the world is your pediatrician. I mean, you have your
hopefully,
your pediatrician. You really rely on them. And if your pediatrician says, "Well, we don't believe in that," that's not real. And to the point where I had one mom whose pediatrician threatened her, says, "If you pursue that, you have to find a new pediatrician." I mean, this is these are the kind of stories that come in. So this, to get back to your question, so that they're not being taught. I think they know about it probably from psychiatry or neurology. They don't know about it from pediatrics. And hopefully this poster we're going to do this fall, it'll get published. So that's the other problem. These papers don't always get published. It was accepted as a poster. I wanted it as a podium presentation to really get the impact, because not everybody looks at posters. But at least we got on the program.
It's a foot in the door.
Yeah. So, but again, will they pay any attention? Will the people, at Hopkins and places like even right here in town and Children's across town, will they pay any attention to it?
I think the change has occurred, though, in the past 5 years or so. And I always think with the beauty of a poster session is that there's a lot of time for conversation for those who are interested and come by. Because if they weren't interested, they're probably not going to go to the talk either.
Well,
but you might get them walking by.
Yeah.
Dr. Harley, this was super.
Yeah.
Thank you so very much.
Thank y'all for inviting me.
This concludes episode 5 of Untangling Pandas and PANS. Thank you for listening. For more information about Pandas and PANS and the Alex Manful Fund, please visit thealexmanfulfund.org. The content in this podcast is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.